Action.
Come in. Whoops.
Alright. Hello Meredith, I'm John. I'm going to be doing a head and toe examination on you. But first I'm going to wash up real good. So how are you doing today? Everything going alright?
Pretty good.
Anything I should know about before we start the exam? Okay. So you know this water will run warm eventually, you just leave it on long enough. Alright. Okay, alright Meredith, we're going to start off doing vital signs, and the first thing I'm going to do is I'm going to take your temperature and your pulse rate and your respiration rate.
Okay.
So I'm placing the thermometer inside the probe cover just like this. Alright, take off these two parts, put that in the trash. I'm going to turn it on, and then I'm going to have you open your mouth and put this underneath your tongue, okay, just like that. And if you could hold it just so I can see it, that would be really great. Alright, next thing I'm going to do is I'm going to find your radial pulse. Very good. Well, that was really good. That was really fast. Well, great. Sometimes these are slower, sometimes they're faster. It came out as 98.5. If it takes longer, then just go ahead and let it run while you're doing the rest of the stuff. But we're going to go ahead and carry on, and I'm going to do your pulse rate, and I'm going to check your, inconspicuously check your respiration rate. I'm going to check this for 15 seconds. Very good. Okay, and then I inconspicuously watched you breathing, and I have my hand here to see if I could feel those breaths also for 20 seconds. I'll take that number that I had for 20 seconds, multiply that by 3, and take this number right here that I had for 15 seconds and multiply that by 4. You had 4 breaths here. That times 3 is 12, which is in the normal range, and your pulse rate was about 25 or so, and that times 4 is around 100, but that's okay. You might be just a little bit nervous right now, because earlier we took it, it was about 89 or so, okay? Alright, next thing I'm going to do is I'm going to check your blood pressure. First thing I do before I check your blood pressure, I'm going to find your brachial pulse right here underneath the bicep. And I found it right there, the brachial pulse right there. Okay, the next thing I'm going to do is I'm going to estimate your blood pressure. Now I want to make sure that your brachial artery is at the same level as your aorta. Okay? So I'm going to set this pillow in here so that the brachial artery is at the same level as the aorta. Alright? I'm going to estimate your blood pressure by feeling the radial pulse. As I pump this up, I'm going to pump it over the value that I feel the radial pulse disappear, and then I'm going to let the air out slowly until I feel the radial pulse come back. This bag right here has a dot right here that says artery. I'm going to make sure that that dot artery is lined up right over your artery right here. Next thing I'm going to do is I'm going to make sure there's no clothing in the way. And this is 1 inch above the antecubical fossa, right there. Okay? So it's right on the artery right there. We're going to put this on nice and snug, so it doesn't slide around, so get about a finger inside of there. Alright? Orient the bulb so I can know which way is turning it off. I'm going to feel that radial pulse and watch the meter. I'm going to pump up until your pulse disappears. And I'm going to slowly let it out until I feel the pulse resume. Okay, I felt it resume right around 100, alright? And I know you have low blood pressure sometimes, so that makes sense. Alright, we're going to leave that on there. Whenever I want to start all over again, pumping this up and make sure you get all the air out of here first. Okay? Now we'll take the stethoscope and put the stethoscope on bell to listen for the corticoff sounds. Alright, we're going to listen right here over where we found that artery. I'm going to pump it up 20 to 30 millimeters above my estimated value. So I'm going to go up to about 135 or 40. Okay. All right, I found your blood pressure to be about 100 over 60. Is that normal for you?
That's pretty
Okay.
good.
You'll notice that when I was letting the pressure out of the sphygmomanometer, manometer, I was letting the pressure out so that when I was taking the readings, it was coming out about 1-2 millimeters per second, or about 1 beat per drop in millimeter. That way I can get a good accurate reading. Okay, that's it for your vitals. Next thing we're going to do is H-E-E-N-T. So we're going to start by looking at the head, all right? So I'm going to just look at the head from a distance right here, and I'm always keeping in mind to go from least invasive to most invasive. Do you have any problems that I should know about in your head before I start looking around?
Yep.
Okay, I'm just looking at the scalp right now, seeing that there's nothing looks unusual right here. Now I'm going to go through and look at the skin underneath the hair. And to do that, I want to make sure that I go through and pull the hair out of the way as much as possible to see as much of the skin on the scalp, looking for any signs of trauma or abuse or infestation. If your patient has their hair up, they're going to let the hair down so that you can get behind and look in all the creases and crevices. You want to make it your objective to try to see as much of the skin on the scalp as you possibly can. All right, so I'm just going to go in layers, looking through the hair, trying to see as much of the scalp as possible. Of course, if you have somebody who's got shorter hair, this will be a much easier examination, but we can still go through and try to see as much of the skin as we can. Now, if you have a patient who's taller than you, don't hesitate to ask them to put their head forward so that you can also look through the top of their scalp right here for any signs of trauma or abuse or infestation or anything of that. Okay? Good. Now, after I've looked through all the skin, the next thing I'm going to do is I'm going to palpate the scalp, feeling for any areas that might be out of sorts, or seeing if there's any tenderness on the part of the patient. Okay, and I will make it my objective to feel as much of that scalp as I can. I'm feeling it bilaterally, so I can feel one side versus the other side. Okay. And it also makes your patient feel like they're getting a little head massage too, which isn't so bad. Okay, is that okay? Mm-hmm. All right, I'll give you a second to collect your hair if you need to. All right, next thing I'm going to do is I'm going to look at the eyes. All right, I'm going to start with a visual inspection of the eyes, just looking at both sides. Any problems with your eyes that I should know about? Okay, now the next thing I'm going to do is I'm going to ask the patient if they could just pull their eyelids up. Now would you look up this way, put your chin up, now put your eyes down. Good, and look back and forth like this. Very good, I can see all kinds of areas up in the square. Now once again, put your head this way, all right? Pull your lower eyelids out, look up, and then look around on the other side. Excellent, good job. All right, now the next thing I want to do is I want to check your visual acuity. So I'm going to use the Snellen chart, and we're going to hold the Snellen chart 14 inches away from the patient, which is about an arm's distance like this. The patient can hold it just like that. We're going to check one eye at a time, so would you mind please covering one eye and reach for me the smallest line you can on this chart.
428739.
Wow, okay, that is 2020. If I go right across here, I can see what the numbers is, 2020, okay? Go ahead and use your, close your other eye now. Read the smallest line that you can. This time read it backwards.
937824.
Very good, okay, excellent. That's definitely 2020 on both sides. All right, next thing I want to do is I want to check the, what's called visual fields by confrontation. Well, no, I'm sorry. I'm going to do the extraocular motion first, and that's called making the big H, all right? So what I want you to do is I want you to hold your head still and just look at my finger right here with your eyes. Follow with just your finger. Follow with just your eyes, okay? So I'm going to go across here, and I'm looking to see at the end of their ocular range. I don't want to go too small. I want to make sure I get the full ocular range when I'm looking at their ocular movement. And so I'm watching her eyes as they're watching my finger. Excuse me. Now I'm going to do what's called convergence and accommodation. So I'm going to go in towards the nose, watching the eyes come together, and then back out again, watching them come back out again like that. Alright, very good. Now what we'll do is we're going to do something called visual fields by confrontation. And in this, what I'm doing is I'm checking to see if her peripheral vision and my peripheral vision about match up. So to do that, I want to pretend like there's just a piece of glass right between the two of us. And I'm going to introduce something into that plane of her vision, right, so that we can both hopefully see it at about the same time. Now if you would please cover one eye, and I'm going to cover the mirror image eye. I want to make sure that I'm at the same eye level as the patient. Now I'm going to start right here at 12 o'clock, and I'm going to come down into our plane of vision. You tell me when you can start to see my fingers wiggle.
See?
Okay, good. About the same time I did. I'm going over 7.5 minutes on a big clock, or you can think about it as all 12 cardinal directions on a compass.
See?
I can see that too.
See?
Uh-huh.
See?
Okay, good. Now you keep that eye covered. All I'm going to do is just going to switch my hands here so I can reach out to this side over here. I'm going to bring this into her plane of vision. You notice I'm going nice and slow so that she can see when the finger comes into the vision.
See?
Mm-hmm. And this is the last one right here.
See?
Very good. That's one side. Now we'll do the other side. So cover the other eye, and I'll cover the other eye too. I'm going to do the same thing one more time. Bring it into her plane of vision.
See?
Uh-huh. Notice I'm staying on the same eyeball level as she is. She's looking right directly at my eyes, and I'm looking at her eyes.
See?
And we're just looking at the peripheral vision.
See?
Keep that hand just where it is.
See?
Sorry.
See?
Uh-huh.
See?
Very good. Okay, now what I'm going to do is what's called simultaneous stimulation. And I'm going to check and see if the peripheral vision is the same on both of her sides. Even though we could both see this movement right here, I want to check and see if it's the same on both of her eyes. So what I'm going to do is I'm going to go behind her like this and introduce something into her vision. Look straight at me and tell me when you can start to see my fingers wiggle. Okay, I'm going to hold that hand still. I'm going to bring this hand in now. Very good. Now I'm going to do a little test here. Which side do you see? Which side do you see? Which side do you see? Now which? Very good. And I can look and see on both sides. They're about lined up just the same. Okay, very good. Next thing I want to look at is what's called pupillary response to light. You can either use a pen light or you can use the otoscope right here. And if you would please, just turn slightly so we can have a look at you in the camera right there. What I'm going to do is I'm going to take the light source, I'm going to bring it into one eye, just like this, and watch that eye dilate. That's called direct pupillary response to light. I'm going to go into that same eye again, but I'm going to watch this eye instead, and this is called consensual response to light. Very good. Now I'm going to do the same thing on this side, into this eye to watch the direct response to light. Excellent. And then into this eye to watch the consensual response to light. Excellent. We're no longer doing the swinging flashlight test, but if we were, it would look something like this. But that's not part of our exam anymore. Okay, good job. All right, can we please sit forward? Okay, that takes care of the eye exam except for the fundoscopic exam, and I'm going to hold off on that until the very end of HENT. The next thing I'm going to do is I'm going to look at your ears, all right? So I'm going to just visually inspect first, the same way I visually inspect everything. I'm going to make sure that I look behind the ears, make sure there's no problems, no scars or cysts or anything like that. Do you have any problems with your hearing right now that I should know about? Any problem with your ears? Looking behind each ear first. Okay, good. Now the next thing I'm going to do is I'm going to look inside the ears. So I'm going to use just a normal size speculum on the otoscope. Make sure I get it clicked in just fine. Alrighty. Now, what I'm going to do, is this a good angle or not? Okay, I'm going to pull the ear up and out like this. So the ear canal opens up. Alright, and then I'm going to brace myself for the safety of the patient, and I'm going to watch as the speculum is going into the ear. Make sure it's going into the ear canal nice and straight. Then I'm going to look into the ear canal, and sure enough, I see that pearly reflection in there. Everything looks really good. Alrighty. Good. That's one side. This speculum is still clean. If the speculum had any earwax on it, I would change it out. But right now it's clean, it looks just fine. I'm going to pull the ear up and out, guard the patient with the side of my hand, observe as the speculum is going into the eardrum, and then take a look inside. And that side looks really good too. See this silvery cone of light reflecting. Very good. Alright. Okay, let's do a quick little hearing test now. If you would, close your eyes. Okay. Can you hear this sound?
Mm-hmm.
Tell me when you hear that sound again. Very good. Can you hear this?
Mm-hmm.
Alright, tell me when you can hear it again. Excellent. Good job. Okay, that takes care of our ears for right now. Next, let's take a look at the nose. Alright, so I'm just visually inspecting the nose, looking to see if there's any swelling or tenderness like there. Do you have any problems with your sinuses or your nose or anything like that? Okay, very good. And now I'm going to palpate the sinuses. I can push in against the sinuses, see if there's any pain or tenderness associated with that. I'm going to check the ethmoids here too. And another thing I can try to do is I can tap right here. Frontal, maxillary, ethmoid sinus right there. Okay? Good. Alright, I'm going to inspect inside the navel cavity. Nasal cavity, sorry, nasal. Okay. If you would please look back and take your finger and pull your nose up there and make a piggy nose. Okay, once again I'm going to inspect as I'm moving in towards the ear, nose, don't laugh. And now I'm going to look right inside. I only need to go right to the very edge of the nares to see all the way up inside into the terminates. Okay? Once again, watching as I insert it, and then looking all the way back. Excellent. Very good. Okay. Alrighty, let's take a look at your mouth now. Alright? Okay. For that, I'm going to use a tongue depressor. And I'm going to wet the tongue depressor so it slides around inside of our mouth just really easily. I'm also going to use a light source. You have to use a light source and use your tongue depressor. Now open up your mouth, and what I'm going to do, can I have you just turn slightly this way so we can just see it a little bit better up inside the mouth. Alright? Can you see that okay? Alright. Now open your mouth, I'm looking inside, and what I want to do is I want to cover each quarter right down here.
Slide to the left.
Alright? I want to cover each section down here, so I'm going to look and see every place. My objective is to look at every place where the mucosal membrane meets the gum line. Okay? I'm going to pull down the frontals here, pull this out here, and look back in there. Now I'm going to look up at the top up here, pull the front up like this, and then one more time, all the way back into the back of the mouth like that. So that's what you want to do. You want to look very carefully like this, alright? Now, if you would please, put your tongue to the roof of your mouth, and I'm going to hold it up with the side of the tongue depressor, not straight in. I'm looking down inside of here now. Now hold your tongue down and open up real wide, and I'm going to use the side again like this. And I'm looking inside. Now, would you please say ah?
Ah.
Very good. I'm looking at the difference of the soft palate as it raises up there, looking to see if there's any tonsil, see if there's any redness around the tonsils or the back of the throat. Okay? Very good. Alright, next thing I'm going to do is I'm going to take a look at your throat. Alright, so I'm going to move your hair just slightly away a little bit. Okay, any problems with your throat that I should know about? Okay, I'm going to inspect, make sure the trachea is running straight right here. Okay, now the next thing I'm going to do is I'm going to cover the lymph nodes, and I'll just show you on this one side over here, the lymph nodes. I'm going to feel for the occipital, back here, along the base of the skull. Then I'm going to go to the posterior auricular, behind the ears. Notice I'm using my finger pads to feel over the entire region right there. Then the pre-auricular or periauricular, right in front of the ears here. Then I'm going to come around to the tonsillar, right here at the base of the jaw. And then go underneath there to the submandibular, right in here. And then the submental. Okay. Now I'm going to check the superficial cervicals, which are right along the sternomastoid, right here at the base of the jaw. And then the deep cervical, which is just pushing the sternomastoid a little bit out of the way and feeling deep right in here along this region right in there. Okay? Good. Now I'm going to feel the posterior cervical, which rests right on the trapezius, right in here. I'm going to feel right in there for the posterior cervical. Very good. And then the supraclavicular, and have the patient hunch up and feeling right down this cavity here. Now, of course, you'd be doing both sides simultaneously, but I just wanted to show you what it looked like on one side so you could see that, okay? Good. Next thing I'm going to do is I'm going to take a look at your thyroid, okay? And if you would please turn this way. Very good. Now, I'm going to give you this glass of water. It helps to give the patient a glass of water so they have something to drink when you ask them to swallow. Okay. First thing I'm going to do is I'm going to find myself personally, I'm going to find the thyroid cartilage, which on Meredith is way up here. There's the thyroid cartilage, or the Adam's apple. I'm going to come down from that V that I first feel, down just a little bit to the cricoid cartilage, which is right about here. It's that second little V that you come across. Right down from the cricoid cartilage, right here is the isthmus of the thyroid. I'm going to have the patient swallow. Very good, okay? Take a drink if you want to. Then I'm going to go out to either side of the isthmus of the thyroid to feel the two lobes of the thyroids, here and here. Okay, very good. Swallow. And that was just great. I don't feel anything swollen or anything. Okay, very good.
Thanks.
Okay, let's take a look at the fundoscopic exam now. Alrighty. Now the first thing I'm going to do, if you wouldn't mind holding that, thank you, is I'm going to position myself so I'm at the same eye level of the patient. If that requires having your patient scoot down or you to scoot down, you want to be on their eye level. And I'm going to start by looking at the anterior structure of their eye. So I'm going to set up the fundoscope so it's at about a plus or a green 15. Okay? Now the next thing I'm going to do is I'm going to position myself so that I can come in at about a 10-degree angle. And then what we need to do is we need to have your patient look over your shoulder and fix their eyes on one spot. Okay? Now lastly, what I want to do is I want to open the door slightly and turn off the lights so that our eyes can adjust. Okay, we have the lights off and she's looking over my shoulder. Her eyes are fixed on one spot. I've got this set at about plus 15 and I'm going to come in at a 10-degree angle and I'm going to look, bracing myself on her face like this, coming in, and I'm going to look at the anterior structures first of the eye. Okay? Next thing I'm going to do is I'm going to dial down now, looking through the layers of the fundus, looking into the pupil, until the structures inside the eye, the cup and the disc, come into focus. And sure enough, there it is, right there. I've got the disc and the cup in really good focus. Alrighty? And what I'm going to do is I'm going to look at all four quadrants. So I'm going to go look up to the upper right quadrant, across to the upper left quadrant, down to the lower left quadrant, and across to the lower right quadrant. Then I'm coming back to the disc and the cup. Alrighty, looks good. And then I'm going to ask the patient, would you please look into the light briefly? And I caught a glimpse right there of the fovea and the macula. Okay? That takes care of one eye. Let's take a look at the other eye now. Okay, now we're going to take a look at the other eye, and I've reset this back to a positive 15. Now don't forget that you want to use your left eye to left eye, right eye to the right eye. You want to use your left hand when you're looking into the left eye. Once again, I'm going to brace myself on her forehead like this, coming in, and everything's out of focus now until I get right about to here, and now the anterior structures of the eye are in really nice detail. And I'm looking across at the sclera, I'm looking at the cornea, I'm looking at the corneal limbus. Okay, and now I'm going to look inside the pupil, and I'm going to start dialing down again until the structures inside the pupil come into focus. I'm starting to see some veins now. Good, and now they're starting to come more into focus. Once again, she's got her eyes fixed and looking at a steady point, and there it is again. There's our disc in the cup. Am I too far over? Okay, and I'm going to go to all four quadrants again, looking up, over, down, and across, back to the disc in the cup, and then have her just look right into the light briefly. Very good, and that's all that takes right there for a fundoscopic examination. Very good. Okay, now we're going to do the pulmonary examination. We're going to start off by doing the posterior pulmonary examination. I think it's easier to do the exam having the patient turn across the bed like this, okay? And we're going to want to have exposure across their back, okay? So I can see all the lung fields right here. Now, let's have you take a couple deep breaths, watching the shoulders rising up and down, seeing how the chest expands right here. Very good. Alright, the next thing I'm going to do is called thoracic expansion. I'm going to put my little fingers right here at the bottom of her rib cage, my thumbs together like this. Now I'm going to just pick up and put my hands together, take a deep breath in, and that's a good positive characteristic, good positive result right there. Alright, now the next thing we want to do is we want to do our next couple tests, which are going to be tactile firmitus, percussion, auscultation, but we want to open up the lung fields as much as possible. So have your patient go ahead and hug themselves, put their arms on their shoulders. You see how that moves the scapula out of the way, because we do not want to do any part of this examination on the scapula here. We want to go around the scapula so we get the best results, okay? Now this is what's called tactile firmitus. Every time I put my hands on your back, I want you to say 99. And you notice I'm way up here at the very top of the lung field here.
99. 99. 99.
Very good.
99.
So 3 places on a back this size. If it was a much larger back, I might want to do 4 places. But you notice I went around the scapula and then did the lateral part of the lung field here. All right, the next thing I'm going to do is I'm going to percuss. All right, so I'm going to start in the same places where I was doing the tactile firmitus. I'm going to percuss bilaterally here, 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 and here, here and here, and then around to the laterals. And once again, if this were a much larger torso, I would add more spots as I was percussing. All right? So here I'm going to percuss, and you notice I'm running my hands into the area between the rib cage. I'm doing everything off the gown right now, but it's okay if you just are grazing part of the brassiere if it's a female. But everything else is done on the skin. We want to make sure we do everything on the skin. All right. Next thing I'm going to do is I'm going to percuss for her diaphragmatic excursion or diaphragmatic movement. And to start with, I'm going to start at the top of the diaphragm. So I'm going to go to the base of the scapula right here on the mid-clavicular line. I'm going to start right there. I'm going to listen for the change in sound as I'm going down here when I come across the diaphragm. She's just breathing normally right now, and that's called tidal breathing. All right? So let's go ahead and start. Right there is where it changed from a deeper sound to a more flat sound. Now I'm going to hold my finger here. Now take a deep breath in and hold it. That'll move the diaphragm down. Right about there is where it stops. Okay, so that's going to be about 3 centimeters, which is a good diaphragmatic movement right there. I want to make sure I do that bilaterally. Okay, so I'm going to come over to this side. Once again, at the base of the scapula on the mid-clavicular line. Right there is where it turns flat. This side is actually a little bit lower than this side, and that's normal. Take a deep breath in and hold it, please. Right about there is where it changes. And once again, about 3 centimeters of movement, okay? Very good. Now the last thing I want to do is I'm going to auscultate. So let me get my stethoscope out. We're going to use the diaphragm of the stethoscope to auscultate. And we're going to auscultate in the same areas that we percussed and we did the palpation of the tactile firmitus. All right? We're going to use the diaphragm. And I like to memorize this one little line right here. Every time you feel the stethoscope touching your back, take a deep breath in and out through your mouth. Okay?
Okay.
I'm listening all the way through the inspiration and all the way through to the end of the expiration. Okay, very good. And that's all there is for the posterior pulmonary examination. Okay? Okay, now we're going to do the anterior pulmonary examination. All right, and the first thing I want to do is I want to watch the patient breathe again. Now for this, I'm going to have them expose themselves. All right, so most of the patients here will wear a brassiere. All right, she's going to drop her gown like this. And then I just want to watch her breathe. Take a couple deep breaths. Once again, I'm watching the shoulders moving up and down, seeing the lung fields expanding and contracting. Very good. You can put your gown back on now. And I'm going to put her at 30 degrees now for the rest of the anterior pulmonary examination. Okay? Now, a good way to drape for this examination, a good way to drape for this examination is to have the patient take their gown and, go ahead and lay down for a second. take their gown, and they're going to take their gown from the top down and the bottom up and make it into what would be like a tube top, all right? I'm going to go ahead and cover her lower extremities here for modesty. Pull out the leg rest for her, all right? And she's going to pull up here. Now, some of the gals don't really mind too much, but just so we'll know what the best modesty approach is just like this, all right? Now, when I'm going through the examination, once again, I'm going to go around, like I was going around the scapula, but I'm going around the breast, and you need to get actually all the way back up to here. So ask your patient to just displace up so that your hands can go right below the breast for when you're doing the tactile firmitus, the percussion, and the auscultation, all right? My pattern is going to be from the top all the way down to here. We've watched her breathe now, so the next thing we're going to do is we're going to do the tactile firmitus on her body. And once again, every time I put my hands in your chest, I want you to say 99. You notice I'm starting at the top of the lung fields way up here.
99.
And then, once again, we need to be on the flesh, not on the clothing.
99.
Okay, if you could displace up, please, and
99.
very good, all right? Next thing I'm going to do is I'm going to percuss, and just turn your shoulder like this. I'm going to percuss at the top of the lung field here. Very good, okay? And here. Right here. Good. And here. And if you could displace up, please. Very good, all right? Last thing I'm going to do is I'm going to auscultate. Now, if you have a patient who's a smaller patient, you can take the diaphragm, move it over to bell, all right? And you're going to press the bell into this interclavicular fossa right here with a little bit of firmness, so change the bell into a diaphragm. We're going to be doing that. Once again, whenever I put my stethoscope on your chest, I want you to take a deep breath in and out through your mouth, all right?
Okay.
Changing it back to diaphragm now. Good. You can displace up, please. Very good. And I want to make sure that I was listening throughout the entire inhalation and the entire exhalation to the very end of their exhalation. All right, that takes care of the anterior pulmonary examination. Okay, now we're going to be doing the cardiac examination. I have my patient in the same position that I had for the anterior pulmonary examination, which is the bed at 30 degrees. Okay, I'm going to start by observing. I'm taking a look at her neck right here. All right. And then I'm going to palpate the upper carotids here. Good. And this side. Good. And I'm going to palpate the lower carotids here. Good. And here. I want to avoid palpating both sides simultaneously, and of course avoid palpating in the center right there. The next thing I'm going to do is I'm going to observe the JVD. So I'm going to have her turn her head slightly to the right like this. Okay, and tangential lighting is really beneficial for looking at the JVD. Although in this case, with Meredith, you can see the JVD is actually pretty pronounced right at that spot, right there. Can you see that? Right here. All right, we can use tangential lighting like this, or we can also use our tangential lighting right across here, just to help us get a shadow to see across where the JVD is. All right? Okay, now the next thing I'm going to do, I'm going to look at the rest of the chest, and I'm going to look at the four sections of the chest. I'm looking at the aortic, the pulmonic, the tricuspid, and the mitral. Now, first thing I'm going to do is I'm just going to observe, looking at each one of these spots, and just so we know by definition where these spots are, we're just going to go to the sternal crest right here at a 45-degree angle down to the second intercostal space. So this is where I'm going to want to be looking. It's right here and here actually. So I'm observing the aortic, and the pulmonic, the tricuspid, and the mitral. And it's very beneficial when you're observing to also look tangential across these regions right here, because you're looking for thrills, you're looking for anything that might be pulsing like this. The same way we might be able to see the abdominal aorta. If you could please displace upward, and I'm looking across here, and across here right there. Okay, next thing we're going to do is we're going to palpate all four of those regions, okay? So again, I'm going to the second intercostal space at a 45-degree angle from the sternal crest right here, about right there. I'm putting my fingers into the intercostals and I'm feeling for heaves now in the aortic, across the pulmonic. Notice I'm using my finger pads, not pressing straight down, but I'm pressing my finger pads here. The tricuspid, could you just place up please? At the fourth intercostal space on the left sternal border. And then directly across here to the mitral on the midclavicular line at the fourth and fifth intercostal. And I can feel it right under my fingertips, right there. Next thing I'm going to do is I'm going to have a return to the left lateral decubitus, and I'll feel that drop slightly, about an inch. Okay, come on back. Alright, now we're going to auscultate. We're going to auscultate each one of those spots. We're going to start off by auscultating with the diaphragm in each region. Just place that, please. Right over here. Very good. All right, now I'm going to listen to the last two areas, the tricuspid and the mitral, with the bell of the stethoscope. I'm going to use light pressure and just lay it gently on the surface. To the apical. And then have her roll to her side into cubitus. Very good. And while I'm still sitting here with the bell of the stethoscope, let's go back and make sure that we're going to listen to the carotid arteries, uppers and lowers. Now when you're listening to the carotid arteries, have them, they can extend the chin slightly, but also have them take a deep breath in and hold it so you don't hear the air going through their larynx. Hold it. Good. And this side. Okay, take another breath. Ready? Okay, hold it. Okay, very good. Now, the last test I need to do for the cardiac examination is the aortic insufficiency. So I'm going to have the patient sit up and I'm going to use the diaphragm of my stethoscope. Alrighty, I'm going to put it on the tricuspid region, left sternal border, fourth and fifth intercostal. Have them breathe out and lean forward. Breathe out. Okay, very good. Thank you, Meredith. Alright, now we're going to take a look at the peripheral vascular system. Okay, I'm going to start off by feeling the radial arteries simultaneously bilaterally. Okay, checking to see that they're both pulsing steadily, good, steady, strong pulse right there. Next I'm going to feel the ulnars, and you can do the ulnars bilaterally simultaneously if you want to, but you're just required to do them one at a time if you want to. Okay, and here. Good, good. Next I'm going to feel the brachial. Very good. And here. Okay, good. I'm going to go down to the lower extremities now, alright? I'm just going to do an inspection of the lower extremities, looking for any signs of scars or abuse or trauma, alright? The next thing I'm going to do is I'm going to check the popliteals, alright? And the way I like to do the popliteals is just to hook your hands underneath the tendons of their knee, pick up so that you're supporting the weight of their leg, and then use your thumbs as pressure to push down, alright? So I'm going to pick up your knee here, and my fingers are right below my thumb right there. I'm just pressing against there. Okay, good. I can feel it right on this side, right here. And once again on this one, I'm going to pick up and hold the weight of her leg. Just relax. Press in a little bit. And good. I can feel it actually more towards the center on this side over here. Alright, now I'm going to go down here to the posterior tibial, which is right behind the malleus right there. I'm just going to feel it along the back of the malleus, and it's right here, nice and strong right there. Good, strong, steady pulses. And once again on this side. Okay, very good. And then I'm going to feel the dorsal medialis right here between the two tendons on the top of the foot. That's very good. And here. Okay, excellent. Next I'm going to check for pitting edema. So I'm going to squeeze here between the bones and the skin, the lower extremity for about 5 seconds. Release and then feel if the skin comes back, if there's any pits in the skin. That's very good. Alright, the next thing we're going to do is we're going to look at the femoral arteries and the inguinal lymph nodes. Okay? So we're going to drape our patient for this. I'm going to take the drape and I'm going to put it right between her legs here. Alright? Now, Meredith, if you go ahead and lay down, and I need you to expose up to your legs, right here. Expose up to your hip, if you would, please. So just pull up your drape up to your hip, please. Alright? And then it's really beneficial to have the patient pull their leg out like this, like a figure 4. That way you can see everything that's going on. Now, could you please pull up just a little bit more so I can see your hip bone right there exposed? Thank you very much. I want to be able to see what I'm doing when I'm touching, right? Don't go feeling around trying to find what you're looking for. I want to see the hip bone here. I'm going to feel for the femoral artery right straight down this line right here, down the inguinal line. And there it is, nice and strong right there. The next thing I'm going to do is I'm going to listen. Excuse me. We're going to listen for bruits, so we're using the bell of the stethoscope. Okay? And then I want to palpate the horizontal and vertical chain of the inguinal lymph nodes. Would you mind taking your hand and just holding the drape out of the way there? Thank you very much. I'm going to go down the inguinal line right here. Here's my first inguinal lymph node right there. Going down the inguinal line here, so I feel this large tendon right there. I'm going to come across this tendon. I'm feeling inside that tendon right there. Here's my next chain right there. I'm feeling along that chain. And you notice I'm going to do all of one side of her body for the femorals, the auscultation of the bruits, and also the inguinal lymph nodes. Then I'm going to go do the other side. That way it makes it a little bit easier. You can go ahead and drop that side now. Alright, if you would please, go ahead and expose on this side, all the way up to your hip bone. Thank you. And then I'm going to pull the leg out slightly so I can get full exposure to this area right there. I'm going to find the femoral artery, so I just need to put my hand right there and press down the inguinal line. And there it is right there. I'm going to auscultate the femoral artery using the bell for bruits. Okay? And then I'm going to palpate the inguinal lymph nodes, the horizontal and vertical chain of the inguinal lymph nodes. There's the first one right here. I'm just going to work my ways down this chain. Okay, until I feel this tendon right there, so right down the inguinal line until I feel this tendon right there, come across this tendon, and there's the next group right here. I'm feeling inside this large adductor tendon, adductor tendon, excuse me, and there we go, right there. Everything feels just fine. Okay, you can go ahead and drop your drape down. Okay, good. Okay, let's go on to the abdominals now. First thing we want to do is we're going to want to place the bed down at 0 degrees. Okay, so don't worry, I'll lower it down here gently. We want to have the lower extremities covered, alright? Then we're going to have exposure, alright? From, I'm just going to pull this up here. You want to go right below the breast, like this, because you want to have exposure all the way up to this part of the breast. And then you're going to need to see right to the pubic line, or the iliac crest on both sides, just like that. So we want to have exposure like this. Now the next thing is, it's going to be beneficial, some patients don't like this, but some patients it makes it work, to have them raise their legs up like this, and put their hands down. This takes the pressure, this takes the pressure off their abdominal muscles. Their back should be lying flat to the table, okay? And with all the examinations, the first thing I'm going to do is I'm going to inspect. I'm going to look from above, looking for any signs of trauma, abuse. Of course, we got this scar right here where Meredith had her spleen removed. That's very obvious. And then I'm going to look tangential across the stomach, looking for anything that might be bulging out on any sides. Okay, very good. All right. Next thing we're going to do, always, whenever we're doing the abdominal examination, we're going to always auscultate before we do anything else, before we touch anything else in the stomach. We don't want to disrupt the gastrointestinal bubble. So I'm going to auscultate the 4 regions. So just imagine taking the stomach and dividing into 4 sections right here. I'm going to auscultate in each one of these sections about 3 or 4 seconds in each one. All right? It could be a total of 10 seconds altogether, or 2 to 3 seconds in each section right here. So listen for bowel sounds. Okay. All right. All right, good. Next thing I'm going to do is I'm going to percuss. I'm going to percuss across each one of these regions again, or basically I'm just going to percuss around in a circle. I want to always make sure I'm going in a clockwise direction to the patient. This is the way the intestines flow, so you don't want to go against the grain. Very good. Okay. Now, after that, the next thing I'm going to do is I'm going to palpate. Well, before I start palpating, let me go ahead and percuss the liver span here. So I'm going to start on the umbilicus right here, at the midclavicular line right there. I'm going to percuss from here to just right below the breast right there. Nice, hollow, empty sound. Starting to flatten out. Definitely flat there for sure. We're over the liver. There, we're over the liver. Still, and a little bit higher. And it starts to get hollow again, right in there. So our liver is right about here, just where we expected, about that same size, okay? Now, I'm going to start with light palpation. I'm going to watch the patient's face the entire time I'm palpating, okay? I'm looking for apprehension, I'm looking for signs of the stomach tensing up, which knows that I've hit a delicate spot. Just a light palpation to start with. Everything okay? Does anything hurt? Okay, good. I can feel things actually moving around a little bit in there. Alright. Now I'm going to do a little bit deeper, and I'm just going to keep my hands flat the way I had it the first time, but I'm going to put my second hand on top, and I'm just going to press down a little bit deeper, very gently, just to see if there's any pain or tenderness as I'm going down into the abdominals. Everything okay? None of that hurts? Alright. Here we can tell if the bladder is distended right in here, if we feel it pushing it back against our hands, especially my little finger right there. Okay. I'm going to come back to this spot now that I've been pressing in nice and deep. I'm going to come back to here. I'm going to put my hand underneath her rib cage and just rest my hand along the edge of the ribs right here, just about at this lower section right there. And what I'm going to have her do is I'm going to just keep my hand relaxed here. I'm going to have her take a deep breath in, and when they breathe in, you want to establish that they're breathing in through their stomach here. So when you take a deep breath, would you please raise my hand up when you breathe in? Very good. That makes me know that she's diaphragmatically breathing, so the organs are moving down this way when she takes a deep breath in. Okay, you can relax now. I'm going to take my hand here, and I'm just going to slide it underneath the edge of the ribs. I'm just going to hold it there to begin with. Go ahead and take a deep breath in, breathe out. As she breathes out, I'm going to slide my hand up underneath here, under the edge of the rib cage, right there. Now take another deep breath in, and right there I felt the liver bumping against my hand right when she was breathing in. I felt it right in that location right there. Very good. Alright, the next thing I'm going to do is I'm going to come down here to where the kidneys are. And the kidneys are located about below the umbilicus right here, a little bit to the right of center. Okay? And I'm just going to put my hand here, alright? Now, I want you to take a deep breath in, through the stomach again, and I'm pushing down when she breathes in. Go ahead and breathe out. And this is where I feel I'm right in this area right there. Maybe I'm a little bit higher, right about there. Okay, good. Now I'm going to come around to this side, and if you're tall enough, and your patient's small enough, you can just take your hand, put it underneath the kidney on that side. This one is a little bit closer to center, slightly lower, right about there. Take a deep breath in. As she breathes in, I push down. Breathe out. And there I have it trapped right in my hand right there. Right? Okay, very good. Alright, next thing I'm going to do is I'm going to percuss for the spleen. Now, of course, Meredith's got a spleen that's been removed, so I'm going to show you how I'm going to percuss for that spleen, but we're not going to expect to find the same kind of sounds right here. So what I'm going to do is I'm going to get on the mid-clavicular, just like before, on the umbilicus, and I'm going to come across this way, across her chest, and make like a little T this way. Alright, so let's go ahead and percuss that. All the way to the midline over here. Then I'm going to come up a little bit. And percuss down that line right there. Okay. Alright, so since she doesn't have a spleen, we would hear the dull sound right about here, right, almost right slightly above her chest, her beginning of her rib cage right there. Alright, now let's go ahead and palpate for the spleen. The way I like to do that is just take one hand, put it behind the back here, okay, and once again it's going to be just like when we were palpating for the liver. I'm going to have her take a deep breath in through her belly. And as she breathes out, go ahead and breathe out, I'm going to slide my fingers just up under the rib cage here, just like that, and have her take another deep breath in, and I'm feeling for a large mass to come to my hands, and I sure don't feel any large mass coming to my hand on that side. And you normally wouldn't either, because the spleen would be not, unless it was enlarged, you wouldn't feel it. Okay? I want to show you one more quick technique for feeling the liver also. This is called what's called the claw technique. And some people prefer this over using sliding their hand underneath there. And the way you do this technique right here is just find the edge of the rib cage, right like this. Roll your fingers underneath the edge of the rib cage, just like that, when the patient's nice and relaxed. Okay? Have them take a deep breath in through their belly. And there is the edge of that liver right there. I felt it at the end of her breath right there. Okay? Now, last thing we're going to do is we're going to take a feel for the abdominal aorta. You can even see that outline of it right there. I'm just going to feel across the stomach here until I feel that ridge. There's a little ridge, like almost like a piece of string, that's running across your stomach, slightly to the left of the center line here. I'm going to come across this way now, and there's the other side of it right there. Okay, this is the width of her abdominal aorta, and I would estimate that as being about 2 centimeters. I don't want to press in too hard on the abdominal aorta. That can be a little discomforting, but I might be able to feel the pulse of the abdominal aorta just gently right like that. Okay, that's the abdominal examination. Okay, so now we're going to move on to the neurological examination. First thing I'm going to do is I'm going to ask you some questions, and I'm also going to take a look and evaluate your posture, see that you're sitting up, you don't look lethargic or tired or anything like that. You look alert and awake. And I'm going to ask you a couple questions for a mini mental status exam. So, could you give me your name, please?
Meredith.
Okay, do you know where you are?
Office of Clinical Skills.
Okay, do you know what season this is?
Almost springtime.
Okay, do you know why you're here today?
To get a physical examination.
Okay, very good. Alright, now the next thing we're going to do is we're just going to go through the cranial nerves, alright? We'll start with cranial nerve number 1, and that's your sense of smell. There's 2 ways I can do that. I can either inquire about your sense of smell. Have you noticed any changes in your sense of smell lately? No? Okay. Or I can go ahead and test your sense of smell. First off, I'm going to just check and make sure that you have good breathing through your nose. So if you just place it up against your nose, cover one nostril and blow. Okay, cover the other nostril. So I'm just checking for patency right now to make sure that she can breathe okay through her nose. And then the next thing I'm going to do, have you close your eyes. All right, would you cover one nostril, please? All right, I want you to smell this sample right here.
It's coffee.
Okay, very good. Would you cover the other nostril? I'm going to have you smell something different. Okay, take a smell.
Smells like peppermint gum.
Okay, very good, very good. All right, now, normally, if we're just doing just the neurological examination, we'd also look at cranial nerve number 2 right now, which is where we could do an ophthalmological examination. We could also do your eye motor reflexes, and we could also look at your peripheral vision. But we're going to move on, since we've already done that, and we're going to go down and take a look at your trigeminal nerve. We'll be testing your trigeminal nerve for your sense of touch in all 3 divisions, okay? So I'm going to make a sharp point. There we go. And I've also got something soft right here to feel. Alright, can you feel this okay? Mm-hmm. Alright, can you feel that alright? Mm-hmm. Alright, okay. Now what I'm going to do is I'm going to look at all 3 divisions bilaterally. So I'm going to look at the top section here, 1 division. The next division is right through here, from there to here. And the last division is right across there. So if you would, please close your eyes. Alright, I'm just going to check sharp touch right now. Can you feel that? Mm-hmm. Okay. Does it feel the same as that? Mm-hmm. Alright. Can you feel this? Mm-hmm. Does it feel the same as that? Mm-hmm. Can you feel this? Does it feel the same as that?
Yep.
Okay, that's all 3 divisions bilaterally sharp. Now we're going to go through and we're going to check soft, so go ahead and close your eyes. Alright, can you feel this? Alright, does it feel the same as this? Can you feel this?
Yep.
Can it feel the same as that?
Yes.
Can you feel this? Does it feel the same as that? Okay, very good. Next thing I'm going to do is I'm going to discuss the corneal reflex. And on the corneal reflex, we don't actually do it, but you do need to show the patient how you would do it. And what I'm going to do is I'm going to take a fine wisp of cotton, just like this, and I'm going to have the patient look that direction, and I'll bring this over to the side of their cornea and see if she blinks. I'm just going to describe it. I'm not going to do it. I bring it over to this side right here and see if she blinks too, and that'd be for the corneal reflex. Okay? Alright, next thing I'm going to do is I'm going to check the rest of the 5. I'm going to have you bite down, and I'm going to feel right over the masseter right here. Very good. I'm going to feel over the temporalis right here. Very good, okay. And then I'm going to check your cranial nerve number 7, your facial. So if you would please, just raise your eyebrows. Now squint them real tight. Good. Puff out your cheeks. Smile. Stick out your tongue. Very good. Alright. Alright, next thing I'm going to do is I'm going to check your gag reflex. And for the gag reflex, I'm going to need to have a tongue depressor. Now once again, we don't actually really do the gag reflex, we just describe the gag reflex. So what I'm going to do is I'm going to describe it to you. I'm going to take this tongue depressor, have you open your mouth, and now I move this to the back of your mouth until I elicit a gag response. But we don't do that for the examination, we just have to describe it. Alright? Alright, next thing we're going to do, let's go ahead and finish up. We're going to do the accessory nerve. And what I want you to do is I want you to just pull up with your shoulders. Very good. Okay. Move your head against, twist your head, turn your head this way, very good. Turn your head this way, very good. Now take your tongue and put it against the side of your cheek and push against my hand, good, and very good, okay? That takes care of our cranial nerves. Now we're just going to work our way down through the muscles as we go right through here. Now we're checking muscle strength, equal muscle strength. So if you would please, put your arms out like this. I'm going to press down, and I want you to press down here, okay? Put your arms like this, pull in, now push out. Very good. Now I'm going to do one leg at a time, okay? Just push up, very good. Now, push down, very good. Push up, very good. And then push down. I do it one leg at a time because if I was going to try to do both legs at the same time, she'd be using her abdominal muscles and not just her thigh muscles. Okay, let's go down a little bit lower. Go ahead and press out with your legs and pull in. Okay, pull up with your feet and push on the gas. Very good. And that takes care of our muscle nerves. All right, the next thing we're going to look at excuse me, is, let's look at your vibratory sense or position sense. There's 2 ways to test vibratory or position sense. The easiest way to test the position sense is just to take the patient's, one of their fingers right here. I'm going to hold the finger on the side like this, and I'm just going to move the finger up and down, just touching the very tip of it right here. Now close your eyes. This will be up, and this will be down, okay? Which one is it?
Down.
Which one is it?
Up.
Okay, we're going to do both sides. Alrighty. Which one is it?
Up.
Which one is it?
Down.
Which one is it?
Up.
You notice that I'm not touching the pad of her finger, the top right here, because she'd have a sense of me pressing here or a sense of me pressing right there. If I were to use vibratory sense, I could take a tuning fork like this, strike the tuning fork, and place against one of the bones right here, and feel the vibration through my finger, and then she would tell me when the vibration started to diminish, and I would see if I could still feel the vibration through my finger here. This is a good little experiment right here, but it takes a long time to establish whether or not there's a lack of sensation due to vibration. So we're going to speed it up a little bit. I'm going to go ahead and do the position sense on lower extremities now. So what I'll do is the same thing. I'll take a toe right here. I'll hold it by the side, okay? I'm going to take just the tip of her toe right there. This is up. This is down, okay? Close your eyes. Oops. Which one is it?
Down.
Which one is it?
Up. Up.
Okay, and once again on this toe, I'm going to hold it by the sides right here. Just push my finger right against the top right there. Okay, which one is it?
Down. Up. Down.
Very good. Okay, excellent. Alright, now, after position sense, we're going to go ahead and do sensory throughout the rest of the body. Same thing we were doing on the face, but we're going to do it on the upper extremities and the lower extremities. I'm going to have to pull this up just a little bit. I want to make sure that when I do the doing the sensory, that I'm going to make sure I do it on the same epitomes on both sides of her body right here, and once again down here, okay? The first thing I'll do is I'm going to see that if she can distinguish from sharp to soft on the distal extremities of the upper, and then I'm going to go ahead and just do comparison across the rest of the extremities. So close your eyes, please. Okay. This is going to be soft. Can you feel that?
Mm-hmm.
This is sharp. Can you feel that?
Mm-hmm.
Okay, which one is this?
Soft.
Which one is this?
Sharp.
Which one is this?
Soft.
Which one is this?
Soft.
Which one is this?
Sharp.
Okay, so she was able to distinguish the two of them. Now I'm going to go ahead and keep your eyes closed. I'm going to go ahead and go through the rest of the upper extremities. Does this right here feel the same as that?
Mm-hmm.
Okay, and does this right here feel the same as that?
Mm-hmm.
Okay, you'll notice that I did the wrists and I did the elbows right there. Okay, let's go down and do the lower extremities. I'm going to do, see if she can distinguish between the two of them right here. This is sharp right here, okay, and that's soft. Can you feel the difference? Okay, which one is this?
Sharp.
Which one is this?
Sharp.
Okay, which one is this?
Soft.
Which one is this?
Sharp.
Which one is this?
Soft.
Okay, does this right here feel the same as that right there?
Mm-hmm.
Okay, and does this feel the same as this?
Mm-hmm.
Okay, very good. Alright, that takes care of our sensory. Now let's go ahead and go through discrimination. We're going to do a test called stereogenesis. Alright, if you put your hands out, please. Alright, close your eyes. I'm going to put something in your hand, and I want you to tell me what I put in your hand. Alright?
Quarter.
Okay, I'm going to put something else in this hand right here, and tell me what that is.
Paper clip.
Alrighty, that's called stereogenesis. We can do a different test which does the same thing. You can do one or the other. This is called graphesthesia right here, okay? You're going to keep your eyes closed. I'm going to let you know this is the bottom of the page right here. This is the top right there. I'm going to draw a number or a letter in your hand, and I want you to tell me if it's a number, what number it is. I'm going to draw a number. You tell me what number this is.
It's 1.
Okay, once again on this hand, here's the top. Here's the bottom. Here's the top. I'm going to put a number in your hand. You tell me which number it is.
3.
Very good. Okay. All right. Our next test after that is going to be the reflexes. I'm going to go through. I'm going to check the biceps reflex, the triceps reflex, and the brachioradialis reflex. Okay. To find the brachioradialis reflex, just put your hand, your finger, about 1/3 up their forearm and just press in here. Now have the patient move their thumb around. Okay. And go ahead and keep doing that until you feel that tendon. There it is right there. I'm feeling the tendon sliding over the skin right here, okay? Let me just turn your hand slightly. I'm going to put my finger on that tendon right there. Okay, look over there. And I'm going to strike my finger that's laying right on the tendon, and I'm going to watch for a response. Okay, and I saw a little thumb response right there. I want to make sure that I do the reflexes bilaterally. Okay, go ahead and roll your thumb around. Okay, there it is right there. Go ahead and stop. Alrighty, and now I've got my finger sitting right, or the knuckle sitting right on that tendon. I'm going to strike my finger, and there it is right there, okay? Now I'll do the biceps tendon, and if you would, please just make a muscle with your arm. I'm feeling that tendon right there, relax. I'm putting my finger, my bone, right on that tendon. I'm going to strike the bone, strike my finger with the sharp end here. And there we go, I got a reflex right across there. And once again, I'm going to do it on this side. Make a muscle for me. Good, relax. And I'm going to strike right here. Good. I saw a little reflex right there. Last, I'm going to do the triceps tendon. So when you're doing that, put the weight of the arm in your hand like this. Make a little saddle. If you have the patient flex their arm out, you can feel this large tendon right there. Okay, go ahead and relax. I've got that tendon located. Now this is the first tendon that we can go ahead and strike just straight up on the hammer. I'm going to use a sharp end right here. I'm just going to strike right there, and I got a little reflex right there. Okay, and once again, I'm going to come over here and stretch your arm out straight. I can feel that tendon right there. And I'm going to strike right on the tendon, just like that. We got a little reflex right across there. Okay, the next one we're going to do is going to be the patellar reflex. Once again, here's our tendon right there. I can feel that. I can feel the tendon right here. Now I'm going to use a flat end of the reflex hammer. Have the patient look away. And also, if you're having a hard time getting the reflex, you can have them make a stressful movement on the top right here and keep that going while you strike the tendon right there. We saw a little reflex right there. Keep that up, please. And I saw a little movement right there. It wasn't the best of possible hits. Okay, very good. All right. Next thing I'm going to do, is I'm going to do the Achilles tendon. So I'm going to pull the foot up slightly. Here's the Achilles tendon right there. I'm going to strike the Achilles tendon from the back right there. And very good. We had that little reflex right there. And once again, I'm going to strike the back of the foot there. Okay, try it one more time. I'm going to wait a couple seconds for the reflex to reset itself. Here's the tendon right there. Okay. Okay, I got a little movement right across there when I did that. The last one I'm going to do is called the plantar response, or the Babinski. And so the legs need to be out at 90 degrees right here. And we're going to go across the foot. If you don't mind, I'm just going to use your foot as a demonstration real quick. I'm going to go across the foot like this, around it over here. And I'm going to use this edge right here of the reflex hammer. So it's going to look something like, I'm going to cross your leg just a little bit. It's going to look something like this. I'm going to just go from here right up to there. And what I'm looking for is a slight in-curling of the toes. Okay? So let's go ahead and try that. Okay, good. Excellent. All right. And this side right here. Very good. Good job. All right. Next thing, after we get through with those. All right, now we're going to do the cerebellar functions right here. So what I want you to do is I want you to take your finger and place your finger on your nose. Now using that same finger, I'm going to hold my finger out here. And I want you to go from your nose to my finger. And I'm going to move this around, and you keep going back and forth from your nose to my finger, from your nose to my finger. Okay, you ready? Go ahead. Now I'm going to go for full extension of the arms here to make sure that there's no palsy. I'm going to go pretty quick too, just like that. Okay, good, that's fine. Now let's go ahead and do the other side. Out. Good. Good, I'm covering all the ranges right here. And very good, and back to the center. Good job, okay? Now what I'm going to do is I'm going to do what's called the heel to shin, and this is going to be for the cerebellar response for the lower extremities. And just go ahead and take your heel right here, put it on your shin, and bring it up and back down. Very good. Other side, please. Up and back down. Excellent job, okay? All right, rapid alternating movements on the upper extremities. One way you can do that is just have the patient take their hand and just move it over, flip it up and down like that on one side. Very good. We're going to do it one at a time, not both at the same time. So go ahead and do this hand now. Good. Now if you could please go ahead and tap your foot. Good. And tap your foot. Excellent. That's always a tough one for me to do. All right. Now the last thing we're going to do is what's called the Romberg. All right. And for the Romberg inspection, the Romberg is okay for certain things, but don't forget that if the patient has diabetes or peripheral neuropathy, you also get a positive Romberg response. And then what we're going to do the Romberg is you just have the patient standing with their heels together. Okay, heels together, arms to the sides, eyes closed, and do this for 10 seconds. And make sure you guard your patient so in case they do start to fall, you can catch them. That's 3, 4, 5, 6, 7, 8, 9, 10. Very good, okay? And that's the neurological examination right there. Okay, the next thing we're going to do is the musculoskeletal examination, all right? I'm going to start off with the spine inspection, so if you would please, Meredith, come stand right over here and turn that way, thank you, okay? Move your hair out of the way here. Now if you would please, untie your gown on the side. Okay, so for all inspections, anything we do, we want to make sure that we see everything that we're to be palpating, okay? We're touching. So I'm just looking at the spine right now. I'm inspecting. I'm looking down the spine, looking for any kind of scoliosis or anything like that. And while I'm sitting here, I can also look at the level of the hips right there to see that the level of the hips are about even. And also gives me an opportunity to take a look at the knees to see if they're knock-kneed or bow-legged. Those all look just fine, okay? Now the next thing I'm going to do is I'm going to palpate down the spine. So I'm going to start right up here at the top of the cervical spine. Work my ways down, all the way down, just feeling across each side of the spinal to see if there's any tenderness. I'm going all the way down to the sacrum right there. Now the next thing I'm going to do is I'm going to go down and palpate, and I'm going to palpate with just the little punches like this, all the way down to right there. Does all that feel okay? No pain or tenderness with that?
Yep.
Okay, next I'm going to check the costovertebral tenderness, which is really part of the abdominal examination, but I'm going to put my hand right here across their kidney and just give a little pop like that. Is that okay? No pain or tenderness? And right here like that, okay? Is that good? All right, next I'm going to do is I'm going to do the range of motion. So you can remember that the range of motion for anything that's attached to the trunk is in 6 directions. So since the head's attached to the trunk, we're going to have 6 directions for range of motion. So I'm going to isolate her here so that she doesn't use any part of her lower back or anything like that to make the movements. Go ahead and look down with just your head. Very good. Look up. Okay, good. Now put your ear to this shoulder here. Excellent. Put your ear to this shoulder. Good. Now just using your head, look over your shoulder. Excellent. And look over your shoulder. Very good. I'm going to do the same range of motion for the lumbar spine right here. I'm going to isolate at the hips right there. I'm going to have you go ahead and bend down and touch your toes. Good. This keeps your gown from coming off too. Now go ahead and lean back. Excellent. Good job. Now reach down the side like you're picking up a bucket. Good. And on the other side. Excellent. I notice that she's got a little bit better range of motion on this side than she does on that side, so there might be a little bit of tenderness there. Now go ahead and twist from the hips on one side and the other side. Excellent, good job. And that takes care of the spine. Let's go ahead and move back to the table now. Okay, now we're going to start with the rest of the musculoskeletal examination, and I'm going to go right down the line. I'm going to do the shoulders first. So you want to have complete exposure whenever you're doing an inspection. So let's just pull down the gown like this just a little bit so I can see both shoulders, okay? Alrighty, and I'm looking to see if they're balanced. It looks like this side might be just a little bit higher. Any pain or tenderness with your shoulder recently? Okay. Now I've looked. Next thing I'm going to do is I'm going to palpate, and that's the same word we keep for everything. If you would please turn slightly this way so we can watch this on the camera. Alright, when I palpate the shoulder, I'm going to come over here to the shoulder blade right there and feel it cross the shoulder blade like this until I get to the acromioclavicular joint right there. I'm going to come across from right here at the sternoclavicular and come across the sternoclavicular. Any pain or tenderness when I do this? Everything feels okay? Now I've got to the acromioclavicular joint right here. I'm feeling across it. I'm feeling the subacromial bursa here. And I can also feel some of it through here. I'm feeling the top of the acromion. I'm feeling the coracoid process right there. And the glenohumeral joint right there. Any pain or tenderness with that? Okay, I'm going to go ahead and do all my palpations bilaterally. Once again, starting at the back of the shoulder blade, coming up across the back of the shoulder blade, feeling for any kind of scapular winging, coming across the sternoclavicular until I get to the acromioclavicular, feeling across the subacromial bursa. No pain or tenderness with that? Everything feels okay? Good. Alright, feeling the acromion here, the coracoid right there, and the glenohumeral joint right there. Okay, very good. Now, if you would please go ahead and put your gown back on again. Next thing we're going to do is we're going to do the range of motion for the shoulders, and this same process is the same for the rest of the body. We're always going to look, then we're going to palpate, and then go through the range of motion. So on this one, this is called the functional range of motion, or what it would be necessary for you to put on a coat or a jacket or something like that. All I want you to do is just mimic my movements, okay? Put your hands to your sides like this. Now I want you to bring your hands up over your head just like this, all the way up. Now rotate them back like this, and back up again to the top. Now this time bring them down this way, like that, and bring them behind your back, and put your hands behind your back. Okay, you'll notice that we took care of internal and external rotation, flexion, extension, and abduction and adduction by just going through those simple ranges of motion. Alright, next thing we're going to do is we're going to look at the elbows. So go ahead and put both elbows out so I can inspect both elbows simultaneously. Okay, any pain or tenderness with your elbow? Now I'm going to go ahead and palpate. I'll palpate the landmarks, the medial and lateral epicondyles here, and the ocrinon. Good. Feeling for any kind of swelling of the tendons or swelling of the bursas. And the same thing on this side. The epicondyles, the ocrinon. Feeling for any pain or tenderness. Okay, good. Alright, go ahead and put your hands out like this so I can look at your wrists. I'm going to break it down so I'm just looking at the wrists first before I go on to the rest of the hands. Does that hurt? Oh, I'm sorry. Let's go ahead and go through the range of motion for the elbows. Thank you. So the range of motion for the elbows is simply flexion and extension. Okay? One thing we don't look at in this examination is what's called supination and pronation. Okay? But you can test if you want to anyway. Okay, the next thing I'm going to do is I'm going to look at the wrists here. I'm going to inspect the wrists. So I'm just looking at this area right in here. Okay? Look at this side here. Looking to see if there's any kind of swelling or tenderness. Are your wrists giving you any problems? Any pain or anything? Okay. Next thing I'm going to do is I'm going to palpate. I'm just going to palpate the radius and the ulnar where it comes right down into the carpals, right in here. Okay. And on both sides, I'm just going to feel across that same area there. Any pain or tenderness associated with that? Okay. Feeling across the carpals there. And once again, the same thing here across the radius and ulnar. And then over here as it comes right into the carpals, right there. Okay, very good. Let's go through range of motion for the wrists. Okay, we're going to do flexion and extension. Okay, and then we'll do radial and ulnar deviation. And if your patient has a problem doing the radial and ulnar deviation, just isolate the wrists here and have them go in and out, just like that. Okay, good job. Now let's go ahead and palpate the rest of the hand. Now I'm going to do the metacarpals. Okay, feeling for any pain or tenderness. Feel that side right there, okay? We'll do this side, a little apprehensive there. That hurt a little bit. Okay, crossed here, across this way. Okay, and the last thing I'm going to do is I'm going to look at the phalanges. And you notice I'm going to feel both sides of the joints just like this, so I can see if there's any pain or tenderness associated with either one of those. Does that feel okay? Mm-hmm. Everything good? Okay, and don't forget the thumb. Okay, good. And I want to make sure that I cover at least 90% of the DIPs and PIPs. Feels like you have a little break right in there. Do you have a little break on that? Okay, good job. All right, now let's take a look at the range of motion for the fingers now. If you would, please just duplicate my motions here. Put your hands like this, and curl your fingers in all the way down like that, and take your thumb and cross it across like that. That takes care of flexion right there, and also it takes care of opposition. All right, now once again, bring your fingers straight up like this. Very good. Now bring your fingers apart and back together again. Okay, and then we'll take our hands like this. This is simple flexion like this, and then this is, this is extension, and then this is hyperextension right here. Very good. And that reminds me that when I was doing the neurological examination, just to throw this in here, is I forgot to do one part of the neurological examination, and that is squeeze my fingers. I'm feeling the strength in our hands right here. Put your hands apart like that. Don't only pull your fingers together. I'm feeling the strength right there. Okay, very good. And then put your fingers like this, and I'm feeling the strength across the thumb just like that. Okay, good. That was part of the neurological examination that I left out, but we put it in on that part. All right, that takes care of the upper extremities. All right, now we'll move on to the lower extremities. Okay, let's go ahead and move on to the lower extremities now, the musculoskeletal examination. I'm going to be looking at the hips, so let's have our patient lay back. And I'm going to pull out the leg rest for her. All right. Now, just like when we were looking at the shoulders or the elbows, we need to see both hips simultaneously, okay? So I'm going to take the drape just like this and ask the patient to just expose both hips at the same time. And I'm just going to be looking straight down like this so I can see both hips at the same time. So they're even, they both look about the same right there. Okay, that's good. Thank you very much. Now what I'm going to do is I'm going to start with one hip. I'm going to palpate all the landmarks of the hip. Now here's a good technique to use for draping. I'm going to take the corner of the drape here, just raise it slightly. I'm going to pass the corner of the drape over to the patient on this side so that she can hold it right up like that and cover herself, all right? Now, here we have exposure of one hip right there. I'm going to feel across the joint line here. The first thing I'm going to do is I'm just going to feel down across into the joint line here. Okay. Now, the next thing I'm going to do is I'm just going to look for the greater trochanter. And I'm going to feel it right here. Now, to help you kind of feel that, you can take the leg and just move the leg like this, and you can actually feel the joint right there, okay? Now, I'm feeling that joint right there. Any pain or tenderness with that? I'm going to feel behind it for the neck of the femur right there. And like I said, if you just move the leg slightly, you can feel back in there. All right, now if I put my thumb right on the greater trochanter and take my fingers and move them this way, I can feel the ischial tuberosity right down there at the base of it. Okay, very good. Let's go for the range of motion of the hip now. First thing I'm going to do is I'm going to do flexion and extension, and I'm isolating just the hip right here. I'm not adding the knee onto that right now. Now let's go ahead and do abduction and adduction, okay? And then we're going to do internal and external rotation. Bring the leg up to 90 degrees just like this, and then we're going to do the internal rotation this way and the external rotation just like that. Okay, and that takes care of one side. Okay, I'm going to go on to the other side now. Excuse me. Once again, I'm going to take this corner right here of the drape. Just raise your leg up slightly, and I'm going to pass this corner over to you right here. Okay, here's my inspection. And then palpation from the, bring your leg down just a little bit, okay? From the iliac crest right here, across the inguinal line right in there, okay? And then coming back over here, I'm just going to raise the leg up a little bit so I can feel the greater trochanter. And then behind that for the neck of the femur, and then put my thumb on the greater trochanter, raise the leg up a little bit, and right back here is the ischial tuberosity right there. Any pain or tenderness with that? Okay, very good. Let's go through the range of motion now, and I can isolate here, and I can do flexion and extension, abduction and adduction, okay? And then the rotations, 90 degrees, and I can do the internal rotation and the external rotation. Okay, very good. All right, go ahead and cover that back up again. Good job. All right, we're going to move down the line now. Let's go ahead and go on to the knees. So I want to have exposure to both knees. Your knees doing okay? Any problems or like that? I'm also inspecting across the lower extremities too. I can see there's a little bit of bruising, maybe a slight scar right there. Looking for any signs of trauma or abuse, any signs of surgery, anything like that. Okay, now let's go ahead and palpate the knees. I'm going to feel across the medial and lateral, collateral ligaments here. Feeling for any swelling or tenderness. Is that okay?
Mm-hmm.
I'm going to feel across the joint capsule, right through here. Okay. Feeling for warmth, anything of that nature. Okay. Going to check for a little patellar subluxation here, and feel across the patellar tendons right there. Okay. Again, isolating one knee at a time. I'm going to take this knee. I'm going to do some flexion and extension across that joint. So I'm going to go up all the way and back down again like that. Okay, let's move on to the other knee now. Feeling across the medial and lateral collateral ligaments right there. Feeling across the joint capsule. Looking for any signs of swelling, bursts, anything of that sort. Signs of apprehension or pain. A little patellar subluxation, and feeling the patellar tendons right there. And I'm not sure about that little scar. What about this little bruise right here? Just hit your knee? Okay, now let's go for the range of motion for the knee, and that would be flexion and extension. A little bit of crepitus right there. Okay, good. Now we'll have to move on to the lower extremities. Okay, now we're going to move on to the distal lower extremities. So I'm going to have the patient sitting up so I can sit down and look at her lower legs. Alright, there you go. Okay. Let's move on down to the ankles now. We've already inspected across the legs, so I'm going to inspect the ankles now. Any pain or tenderness associated with your ankles? Everything is okay? Alright, let's go ahead and palpate across the ankle here. The malleolus, the calcaneus. Alrighty, any pain or tenderness? No? Okay, let's go around this side again. The malleolus, the calcaneus. Alrighty, good. Now let's go ahead and go for the range of motion for just the ankles right here. So if I could have you just bring your feet up and put them back down again. And if you would, just go ahead and point your toes together this way. Just rotate them this way. And out like that, okay? Good. Now the next thing we're going to do is we're going to check for range of motion on the subtalar joint right here. And to check for that range of motion, I'm going to hold the back of her leg here and take a hold of the bottom of her heel here. And I'm going to invert and evert across the subtalar joint. Okay, that would be right down in here, all right? Like that. And then I'm going to invert and evert across the subtalar joint here. So I've got a hold, I'm isolating the back of the leg there, taking hold of the ankle, and inverting and everting. Be careful you don't get confused that with this motion right here. I'm rolling it in and rolling it out. The same kind of motion that you might have if you sprained an ankle. Okay, good. Now I'm going to check what's called the range of motion across the transverse tarsal here. And to do that, I'm going to isolate the heel and take a hold of the top of her hand, top of her foot here, and invert and evert, and I'm moving it across this joint right here now. That's the transverse tarsal right there. Okay, any pain or tenderness for that? And I'm going to invert and evert across the transverse tarsal here. That's isolating the heel and moving the foot like that. Okay, good. Let's go ahead and palpate the rest of the foot joints. Move our ways down the tarsals, metatarsals, and the phalanges out here, and move across the tarsals, the metatarsals, and the phalanges right here. The last thing we can do, which is not necessarily part of our examination, but it's still a good idea, is just go ahead and curl your toes in and spread your toes out, and that'll take care of that. Okay? And that's the end of the musculoskeletal examination.